Good morning, everyone, wherever you are in whatever fair land you might be in. Welcome to the lecture on Integrated Osteopathic Physical Exam. As we are moving more and more towards ACGME, one single accreditation and evaluation system, these osteopathic exams become more and more important, not only for us as DOs, but also for people such as MDs interested in our programs. So your attention to this and your ability to teach an MD while on your program, or MD medical student who is interested in osteopathic medicine, or as we say now, osteopathic neuromuscular medicine. So you're gonna have to kind of OMM. So kind of get used to that. That is the name of the residency. We still consider ourselves OMM. It'll take a while, but I'm sure you'll get used to it. So here's our objectives for the day. We're going to review and demonstrate an integrated osteopathic exam, because an osteopathic exam should not be any additional burden upon the intern or resident. Did you hear me? No additional burden. Only a few extra steps in your regular physical exam of a patient. We're going to review the tenets, the definition of a somatic dysfunction, because it's always on the boards. You would be shocked to see how many people cannot recite or even get the core elements of the definition of somatic dysfunction when we interview them. And it's not stage fright either. Think about that when you interview students. The difference between acute and chronic, indications and contraindications, how to document your findings, because remember, if it ain't on the chart, it didn't happen. Discuss and demonstrate areas for specific hospital treatments. So I will take volunteers from the crowd, and I will ask you what particular diagnosis you are working on and the patient you are in charge of, and I will demonstrate on you, if you like, on you preferably, how I would go about doing an exam on that person and documenting my findings, as well as maybe, just maybe, making you feel better. Maybe. Potential sources of problems. All right, so patient-centered. We're getting back to patient-centered. There's a whole shift in our diaphragm according to ACGM. Diaphragm. Sorry. What's that word? Paradigm. Thank you. You can go first. All right, so yeah, please go ahead and interject where I am incorrect, because that'll make everybody happy. So we're shifting, you know, from the whole system that we were before that really made us sacrifice ourselves and burn out, to a one like, hey, we got to be good before we can make you good. I don't know what the exact name of it is right now, but it'll be out there soon enough. And then we have the whole initiative of preventing patient or physician burnout, your well-being. Yes, I know, even interns, we care about your well-being. It may not seem like it, and you probably, it goes over your head every time we demonstrate it, but we care. We care to have you be the best and in the best shapes. And that's a major shift in our paradigm. Yes. All right, back on track, because sometimes my students recall or remind me I need to focus. All right, so what are the anticipated regions, the highest probability of dysfunctions? All right, the degree in which you're going to follow the patient's problems, key areas, and then you formulate your plan, your examination using your TART findings, chronic, and all that good stuff. All right, so in addition to your admitting diagnosis, or the other reason that they're here, there either can be appropriate differential diagnoses that go along with that may have somatic dysfunctions. Like they come in with a post-MI. Well, they're post-MI because they're in the hospital, right? They'd be acute, they're still here. So they're dealing with that. They can have chest pain still, but it's of the cage. The chest cage originality or thank you. Yeah, feel like Porky Pig some days. So that can be a complicated problem. The diaphragm can be a complicated problem. All these other things that would be treated osteopathically that sometimes we just don't think about when we got our brain focused on dealing with the current problem or the arrhythmia or the acute MI. Developing a proper treatment plan. So, and then the management prescription. All right, so let's go back over the tenets quickly because they're always on your boards. It's a dynamic unit. It's self-healing. Structure and function are interrelated. Always remember that. And that's simple science, you know? And then a rational treatment based upon the three above. Somatic dysfunction. It's an impaired or altered function of related components of the somatic system, skeletal, arthrial, did I say that right? Close enough? Good. Myofascial structures and their related vascular, lymphatic, and neural elements. All right, so tools. History, always history. 80% of what you need to know is in history. Physical exam, focused. Labs and imaging. Data bank. That's how you do it any other way. We just ask you to add the osteopathic point or have that on your mind or in your checklist as you're going through it. It's not that hard. So we focus here. All right, the integrated exam integrates the osteopathic neuromusculoskeletal structure exam with the standard of care examination. So these are the areas. I'm going to let you read those as I drink. Good stuff. All right, so the structures here. What are the high yield? Well, that's what we'll kind of demonstrate as you tell me what diagnosis is of the patients you're treating in the hospitals. It's kind of a fun game. You get to play Stump the Chump with the attending. How often do you get to do that? Never. Visual inspection of the spine, noting any type of changes, particularly in elderly people. What are you going to find? Lordosis of the thoracics, right? Increased lordosis. What? Wow, you were paying attention. All right, so, and then we have our acronym, tissue texture changes, asymmetry, reduced range of motion, and tenderness. Most pain isn't in there. Actually, tenderness is quantifiable. All right, it should be done in at least 2 positions. Hey, if they're on the vent, not going to happen. If you can think of a reason why it's not in the patient's best interest, then document it why it's not in their best interest. So, all right, the exam. So they're in a supine position only due to they're dependent upon the ventilator for respiratory distress, obviously. You know, or they're getting a breathing treatment or other things. They're getting IVs where you just don't feel comfortable moving a whole bunch of tubes and wires and lines around just to get another thing. It's okay. You can look at it later. Considerations. Well, you're going to look at functional units. If you got to get to another area, you can kind of move things around. Think about examining required to the health in the area. You know, look at the other regions around that. Usually progress from the least invasive to the most invasive. You know, if you need to look at the sacrum, starting at the feet's not a bad idea. So, progressing from, we did that one. You know, from the effective and meaningful process. You want to think and have a reason why you're looking at these areas. Why would you be looking at the feet when you're ultimately going to have to evaluate the sacrum? Because everything starts from the bottom and works its way up. You know, it's like the car. If your car's got a bumpy ride, do you start at the engine? No, you usually start at the tires. All right. Limitations and other things that we look at. A lot of times, personnel identifies a task as solely musculoskeletal. In other words, that's not my area. I'm IM. I don't do that. Not picking on IM. They just happen to be someone that came to my mind. They're great people and they do great work. And I got an appointment with Derm coming up soon, so I'm definitely not picking on them. So personnel often don't understand the relevance of the exam. Sure, if you went to another school or another program and they didn't do anything with OMM or osteopathic medicine, you're going like, yeah, sure. So that'd be a good time to educate them. Personnel often underreport the incidence of somatic dysfunction. Yeah, we do. Because if we don't have a service on, they might ask me to fix it. And that's more time I got to spend, even though it's going to make the patient better. That takes me away from stuff that I'm held to be accounted for, like, oh, charts, other things, reading at home. So yeah, tendency to underreport it. Sometimes we don't even ask. All right, general tips. Remember, you're going to be a doctor a long time. Trust me, you're going to get through this. So you're going to be a doctor for a long time. You know, you need to make this as painless, not painful, but painless as possible on you as you're doing your job. Remember that stuff they taught you probably the first week they were here? Proper lifting? Yeah, use your knees. Yeah, well, don't bend over the bed, you know, like you're a butler trying to touch your toes. Adjust the height of the bed. They go up for a reason. They move around. The bed rail moves around. Most of those hoses move around. Just be really careful. Nothing like ticking off a nurse to really ruin your day. But, you know, that stuff can be moved for you to give a viable treatment. And we taught you how to do treatments from the other side so that you can get to the left side when you're having to be on the right side. It's a little more challenging, but you're up to it. You were taught well, and if you forgot, call me. All right, so 4 or 5 minutes. Can you believe that? We're only asking 5 more minutes. It'll take you that long to find a pen in the hospital to write all that stuff down nowadays, 4 or 5 minutes. Because the drug reps don't give it out anymore. Trying to find a pen in the pen in a hospital is a possibly impossible thing to do. All right, concept. Dysfunctional units commenting the benefit of OMM. Yeah, people get better faster with OMM. We have research that doesn't necessarily 100% proves it, but we're getting pretty darn close. And if you want to look at a bang for buck ratio, look at small or post-operative ileus. Think about that. $2 to $8 billion in extra money being spent on extended stays. And I don't mean Holiday Inn. So, you know, if we can decrease that hospital stay, hospital makes money. We're heroes. And current research shows just one treatment, and this is by surgical residents. Come on, you guys are great. Surgical residents are good, but you're great. One treatment improved that. Decreased hospital stay. Billions of dollars saved. Woohoo, we get credit. We don't get the money, but it makes us popular. All right, return to health, optimum function, and the appropriate frequency. You know, we always just try to decide, tomorrow, do they need something tomorrow? Do they need something every day, or can we go every other day? Because every day, like you guys know who work out, and you work out the same muscle, isn't exactly healing if you're working the same muscles. Alternating things every day sometimes gives that day a rest. You got to take that in consideration. All right, duration of time of treatment results in improvement. Sometimes extra treatment doesn't. That comes with experience. This is a good thing to read, especially while I take a drink. Good. All right, indications, somatic dysfunction, pain. Everybody likes the pain to go away. Restricted range of motions, pneumonia. Oh, there's our friend, ileus. Obstruction, constipation, everything. Remember, they don't leave the ICU unless they're passing gas. A surgeon once told me, as I'm sitting in my room after an operation, sends me this joke. It goes, the hospital is the only place that if you pass gas, people cheer for you. I about busted a staple. I told him that. So I thought that was hilarious, considering I was trying to pass gas and not being too successful at it. Edema, lymphedema, something that we don't have enough nurses out there to help. And somatic and autonomic dysfunctions. Contraindications, cancer in the relative area. Pedal pump, we don't know. There's never been an extensive research manipulation with cancer. Maybe we should do some. That's for someone else to decide. Bone disorders, obviously no somatic dysfunction or no HVLA. And vertebral arterial disease, yeah, no HVLA. And sometimes they're not really ready for HVLA when they're in the hospital. You know, it's just not something that we really do. We try to do all the indirect treatments because it puts less stress on the system. So, but oftentimes, you know, a lady is postpartum up in the hospital and her neck's really bothering her. We've treated her by taking, you know, because it's hard to do HVLA in a hospital bed. So we've taken her to a treatment room and worked on her, and she felt much better. All right, frequency and dose, sicker, the less, and dosing more. So more frequency, less harder on her. Allow time to respond, because that's like everything else. You want to see how the antibiotics respond. Concentrate on key areas that are going to provide benefit. Don't worry about the other ones. Findings. This is always a famous quote. Different picture, of course. Looks like he's directing the building of another structure on the hospital. Again, I'll let you read this as I refresh myself. Acute. I'll let you read that because you've been through that before. And chronic. This segmental part probably might mean a little bit more to you now as opposed to medical school, because you can actually relate to it. I have a heart attack. Is my heart really hurting? Is it sending out pain? No, it's calling for help. It's not saying, heart, I hurt, heart, I hurt. I'll say, hey, spinal cord, hey, jaw, hey, left elbow or left shoulder, I'm hurting. Would you tell somebody else? That's my interpretation of that. Because it's sending out things that's causing pain elsewhere. And so by treating those particular areas, you know, that now are yelling back to the heart, hey, I know you're hurting and I'm hurting too, so here's some pain back at you. So you get this vicious loop going where everybody's screaming at everyone else, and, you know, you've been there. You were a kid once, you know, you've watched it. Everybody's screaming, what is the best thing that could possibly happen? Shh, quieting everybody down. Stopping the fibers and pain from being signaled to all places. How do we do that? Well, we treat the heart condition, and we also treat the somatic dysfunctions that were referred from that. Stops the cycle. All right. Again. All right, so typical areas you want to look at: the OA in the cranium, AA in the cervicals, thoracic inlet, especially in the hospital, because they're obviously there for something that's taking a beating, such as, you know, not opening up and not allowing traffic through it back and forth. Ribs, particularly the first rib. Clavicles, because things always get pinched under there, right? And the sternum. Thoracics, types 2 are usually the more acute. They're usually caused by whatever they're in there for. Abdomen, probably one of the things that you should never, ever, ever forget, because the abdomen is so important, particularly the abdominal diaphragm. You know, strengthening that causes and replaces all that negative pressure that creates that vacuum effect that draws blood back So we have that. In addition to that, it helps the respiratory cycle by the negative pressure and so many other things. I'll just skip that for now. So forgive us, we're listening to a hospital page. And then, of course, you know, your sympathetic tone and the lumbars. Pubes, you know, especially with knees and problems that are in there. They have knee replacement. Oftentimes, they can have somatic dysfunctions in those areas that can, you know, that can cause them problems trying to get out there and walk as they're going through PT. And then there's the sacrum. The sacrum is kind of like the automatic transmission of a car. It does so many things that it's just amazing. And when it's out, you're not going as slow forward, and you're not going very slow. You're not going very fast backwards either. So fixing that helps so many different things. All right, the upper extremities, I'll let you read that. Particularly in post-stroke patients, a lot of times they have the, whatever the new version of sympathetic dystrophy is. What is the new word? Chronic something? Okay. Yeah, regional, something chronic regionals. I don't know. Nah. Yeah. Yeah. Thank you. What did you just say? So for the audience, reflex sympathetic dystrophy is the one that I always call it, but it has a new name, and I'm sure you can look it up. Complex regional pain syndrome. It's tough to make an old dog with new tricks. Lower extremity hip restrictions, knee restrictions. Okay, if they had their knee worked on, you're not going to work on that knee, unless you just crave to have the wrath of an orthopod taken out on you. Sympathetic innervations. You should have this information, regardless of what source it is, on your flashcards before you take any boards, because I can guarantee there is at least 1 or 2 direct questions and 2 or 3 indirect questions that you need to be aware of. And don't worry about the end ranges, you know, because when we write board questions, we try to put something in the middle of the target, okay? So upper GI, we're not going to put it at 6 or 8, because, you know, some books may not have that range. We're going to put it dead on 7. Just so you can't challenge us and give us more work. All right, so again, we talked about putting the environment in a situation that allows you to benefit the patient. Get the bed height, head right. You know, get the bars, rails, what are those things called? What? Side rails, yeah. Get those down and out of your way. You know, utilize the sheets to slide your hands under, pull the bed back a little, always remembering that you're going to return it to the condition which you received it. Because if the bed rails were up and they're not up when you leave, you shouldn't have left. Because 1, you put the patient in danger, and 2, you probably ticked off a nurse. So there's 2 counts against you. Not a good thing on a day. Patient's comfort. You know, you're going to have to move some of those pillows that they were put under them to try to make them comfortable. Remember to put them back. That's a good thing for a student that's rotating with you to remember. And your comfort, because you're going to be doing this all night long or all day long. So, all right. So keep the nurses happy. Don't pull out IV lines. All right. So this is something we've added, and I've got a handout. The reason I've got a handout, one of your milestones, particularly in some of, probably all of your programs, I don't know, I haven't checked for sure, has something on professionalism. And we emphasize this is because it used to be when you were in the hospital or in a physician's office, it was assumed that you were going to be touched. Well, in our day and age, it's more of we expect you to tell us that you're going to touch us and ask our permission. Unless it's an emergency situation, and then they just throw up the gown and come out with the shaver because you're going to get a cardiac cath, and they don't even ask you, which time is muscle, right? They don't have to. But normally you got to ask them. And so what you want to do is you want to, tell them what you're going to do, why you're going to do it, get their permission, And I hate to say it, most importantly, document it in your SOAP note. Because if it didn't happen on the chart, it didn't happen. If it happened on the chart, it's words of wisdom that will save you from bad attorneys or yourself. So the reason I put this on there and gave you a handout is just to emphasize. Plus, it's one of my requirements to educate house staff, especially my own, of the need to do this. We did it with the first years Tuesday. Yeah, so, and they took it. Of course, they are first years. They still believe. They're not, you know, not like second years, third years, or fourth years, you know, but this is an important fact that needs to be remembered and as you do things, because it protects you while you're helping others. Remember, you want to put your kids through college, not somebody else's. Osteopathic approach. All right, go ahead and read this. Close enough. All right, techniques and treatment dosage, considering each patient. The frail 70-year-old, she's not going to tolerate, they shouldn't ever tolerate HVLA. So again, let's go ahead and remove any point between the base, sacrum, the pressure of the nervous system, the flow of the intravenous. So, all right, treatment order for pulmonary problems. So whenever I think of what order I should go in, I usually think of what bad can happen if I don't. So thoracics, you know, you want to get the thoracics, you know, going, because what's connected to the thoracics? Ooh, I know, ribs. And then the diaphragm, because, you know, you got to treat the thoracics first because they're connected to the ribs, and a rib dysfunction is related often to what the rib head's doing. The diaphragm, that's probably gold. You know, that's the gold standard. That makes everything better. You get that diaphragm working, everything gets better. You get the negative pressure, you get the flow, you get the rhythm, and everything else. The sternum, another big helper. That's where you have that pump ribs. So if the sternum's dysfunctional, you're not getting these upper ribs. What do these upper ribs do? Where are they near? The heart. And if you're getting a whole bunch of stuff down below with the bucket handle, you're just creating more pressure on something that isn't working. So you got to get the whole system working. It's like you got a hole in the hose at both ends. You know, you might fix it at the end, and all of a sudden the pressure builds up and it blows because you don't have a strong enough hold on both ends. All right, that wasn't my best. Wasn't even close. All right, so the head, parasympathetics. You want those rest and digest systems going. You want them to be going extra fast, you know. In fact, in small and postoperative ileuses, they have gone from lumbar epidurals to thoracics just to overcome some of that problem. Sacrum and lumbars, you want to get that moving because oftentimes the mechanism, if in the cervicals and other areas, can be locked up by its distal connection in the sacrum. Small little things, but small little things matter. Okay, so appropriate level. Remember your flashcards. I always put those sympathetic levels on flashcards. That way I could go through them right before the exam. Sympathetics, rib raising. And rib raising, why does that help so much? It's okay, I wasn't asking. I was asking a rhetorical question. Why does it help so much? Well, one, you're moving lymph. And what's in lymph? All those great little cells that make things better, right? Or identify things. So you're moving that stuff. In addition to you're activating initially you activate the sympathetics, which is, you know, fight and run. And by the time you're done with the rib raising, you not doing it causes the other system to kick in, the rest and digest from the, yes, I know. So don't forget your ganglia too, so in the abdomen. So the whole thing is that if you've ever been on a medevac helicopter and you're not in the captain seat and you're not in the nurse seat It's not a very good ride, trust me. It's not. You know, and I've been on helicopters before. I really enjoy flying on helicopters. I had an opportunity to be a flight surgeon, and like an idiot, I passed it up. But that was 12 more weeks and another opportunity to be deployed. And I still miss that to today. But the first time I was on the helicopter after about 20 years, I go, oh my God, I love this. But can you imagine what that person is saying who's in the stretcher, laid out, going someplace to get better help? It's, oh my God, I hope I live through this. And their sympathetics are running high. So by calming down those sympathetics, you know, you're going to have an opportunity to help them get into a better rest and digest mode much faster. Now, am I saying jump on them the minute they get off that plane? No, but there's time to do these techniques. Yeah, you'll never hear it. OMM, stat. God, I hope not. That'd be a whole new level of service. But we could do it. We have the technology. We have the men out there. Yeah. Okay. All right, so let's get into this particular area, sympathetics and parasympathetics, direct myofascial, which I know. Fascial patterns. Fascial patterns are like the frame of your car, okay? You can damage your car, get the paneling fixed, get everything fixed. It looks great. But when it goes down the road, it still shimmies. Why? Because the frame is still bent. And well, fascia is much like that. You know, if you don't fix the fascia, and a lot of times you don't even notice that there's a problem until about the third visit. That's when you really fix the problems. Abdomen, different techniques, doming of the diaphragm. Lymphatic pumps, this way. Now, the thoracic pumps, thing you got to remember is whether they have COPD, because in COPD you don't want any recoil. You don't want to push on this and then get the that's the recoil. COPD, no. You can do it gentle. It's like you don't want air capture. All right, CV4, the master reset button, as I like to call it. Thanks. Questions before I start the stump? All right, you were first. What is a patient on your service? I'm going to move over here. Yeah. On your service that you're treating, that you would like to know what to do osteopathically? Come on down. You signed a waiver. I'm not worried. Take it off. I'm good. I can go through a white coat. I just don't want anything that's on that white coat.
I have COPD.
Oh, come on. Sit down. COPD. All right, so we just talked about that. I am not going to do the recoil. Okay, so when you think about COPD, and he's a prime example, you think of a large, I shouldn't bring it like this, more like this, more barrel chest, you know, like this. And I'm not picking on him. I could pick on a thin person and do it just as well, but it's going to be a much better demonstration. So I'm going to be thinking about that. I'm going to be thinking about the sympathetics, parasympathetics, the sympathetics. So go ahead and turn around so they can't see you laugh at you, because they're not nice people, but I am. So you want to go down the spine. Where should you be thinking about this? 1 through 6, because you got your flashcard out. So also you want to think of the ribs, deep breath in and out. Yeah, so he's got one that likes to go, one that doesn't. Deep breath in and out. You drinking enough liquids on duty? Not coffee, I mean like real water.
Maybe probably not.
Probably not, yeah, because this rib, you know, how the ribs down here kind of give you an indication of how your kidney function's working. So you might be losing that one. So you might want to drink more water. All right, so quick assessment. Anybody time me? Go ahead and lay down on your back. Yeah. Careful. I've been known to pull out wires, cords, IV lines, microphones. All right, so first thing I'm going to do, just look at his parasympathetics. Do some gentle stuff. Making sure, taking a deep breath, let it all the way out. There you go. Wait for him to breathe. If they're on a ventilator, you just wait for the ventilator to go. And then position it to a new place, go through 2 cycles. Okay, you got that area. All right, so the other thing I'm going to do is rib raising. Rib raising, multiple ways to do it. First thing you do when you do rib raising is be on the posterior angles, not on the rib heads. That is paraspinal inhibition or treatment. So remember I told you, what do you do if there's so many lines over here you can't get to it? You reach all the way across on the side. You can actually lift the other side. And you only have to lift it as much as you can. If they're breathing on a ventilator, go with the ventilator. You know, if they're breathing slowly, go with it. Because anything you do, particularly that goes with the system, seems to help just as much as you going rapidly. The weller they are, the faster you can go. So, anything else hurting? Okay, give me a So if you can, and they're stable enough, I'd probably treat the upper thoracic. Scooch up a little.
Up towards.
Yes, yes. There you go. Let your head drop off just a little. All right, so this is the part where I try to make the resident feel better. All right. Cool. Now, typically I don't jump. That was a controlled fall. So anyway, all right? All right, so then I would do adjusting of the diaphragm and then the celiac and other ganglia, okay? And that was probably, what, 3 or 4 minutes? Okay? All right, who's got another one? Come on, how often do you get to play stump the chump with the attendee? I guess you guys do it way too often because this need is not, you want? Or you're just holding that pen up? Come on. Go. You can take your coat off. You have a patient with what?
Chronic headaches and vomiting.
Okay. Are they related or?
Maybe.
Mm-hmm. All right, so just sit here. So usually you've already got a history, so, and kind of know what's going on. So headaches, you know, first thing you want to know is where are the headaches? In my head, doctor. How'd you get to medical school? Those aren't funny jokes, especially when the patient tells you. Kind of, is it right up here?
Right here.
Right there? Oh, okay. So ask her if she bumped her head, run into anything, you know, had any recent automobile accident. Yes?
Yeah, she fell down the stairs.
Ooh, how many stairs?
7.
Oh, abusively falling down? Somebody pushed her or just fell?
No, she has MS.
Oh, okay. How's she doing with the headache?
I can't get it to go away.
Okay. Is there any headache pain back here?
No.
No. Okay. And then she's vomiting,
Mm-hmm.
projectile vomiting.
Mm-hmm.
She's vomiting up her food.
Mm-hmm.
Is she able to keep it down?
A little bit with some Phenergan.
Okay. So I would probably just look up to the upper part because you got to document that you looked at the spine, right? How hard is that? You know, I had a cardiologist complain they had to do osteopathic exam, and I go, really? So you're already listening to the heart, right? How hard is it while you're listening to the heart to run your hand down that back? But I was an intern. Actually, I was a resident, and I decided that it was not in my best interest to point that flaw out in his practical scheme because cardiologists are hard to find. A lot harder to find than I am. Go ahead and lay down on your back. So I would probably, because it's due to a fall, and it can be related to a structural problem, I'd ask her about her smell. How's your sense of smell? Or how's the patient's sense of smell?
Amazing.
Oh, okay. Because a lot of times when you take hits here, you hit that cribriform plate. Thank you. I appreciate all those nods out there. Yeah. And oftentimes your sense of smell is decreased or impacted. So as we know that this midline bone here, it does have its own little suture, but it's gone. So is it tender right there on her, do you know?
Mm-hmm.
So what about out here? No?
Mm-hmm.
What about here?
Mm-hmm.
There too. So maybe she having any tearing incidences or anything?
Tearing?
Crying, inappropriate, welling up of her tears or anything? No? Okay. So what I do is I'd probably do a micro cranial exam, just kind of see, osteopathically what's kind of moving, what's not moving on a micro level. I mean, you don't have to sit there and try to listen to the CRI or anything like that. Just feel what's moved, what's not moving. So it likes to go this way. Likes to go this way. Likes to go this way. So then I feel the frontal. Can I get it to come up? Do I think it's actually moving? So that may be hard, especially when she's got pain right there. So one of the things I might just do is just do some gentle cross thumb. I'd also ask her about the lights. Are the lights bothering her? Because, turning the lights off with the treatment is good. Unfortunately, the camera can't see you.
I'm okay with that.
But you're not helping to benefit others, which I don't care about anyway. They'll get used to it. Remember, always put your patient before your pride. We're going to yell at you anyway, so it really doesn't matter, and you'll feel better. I would also work on her OA and AA just to try to take any additional tension. Often headaches have a tension headache component that if you treat the thoracics, because they're coming up the paraspinal muscles, treat the upper thoracics, the cervicals, and the OA will take that, what I call the fire starter, and then try to treat the mastoid processes. I've had headaches most of my life. I found that, not necessarily the cranial treatment helps immediately, but when they return, the severity is usually decreased. And 1 or 2 bumps down or notches down on a migraine headache is a blessing. I know it's getting close to leaving time. If you got to go, that's cool, but I still got 5 more minutes. Is this okay? No?
No, I just didn't know what you meant.
Oh, hi, I'm Dr. Halma. I'm here to work on your headaches.
Tell me before you touch
I
It scared me.
see, right? This is why we do this. You're so great. Thank you. I need to place my fingers on your nose and gently, not try to move them, but just gently kind of move slightly, just
No, I
vector
can't.
them.
Oh, okay.
Okay. Thinking, how would you explain it? Is this okay?
Yeah, that's fine.
All right. So do I have your permission?
Yes, I'm sure.
I'm going to put it in my chart because I think that she would sue, but I just,
It feels so good.
You need your neck cracked? You like your neck cracked?
Yeah, sure.
Okay. You don't have to.
It's fine.
That's the other
not
thing.
about me right now.
Yeah, it is. Right now it's about you.
I'm okay with that.
Okay. The other thing I always ask is, like, sometimes, particularly at Kirksville, there's an anticipation that they're going to have HVLA. They grew up on it in this community. And some of it's just customer service. We can train you well enough if you already don't have the training so that you can do everything and not have to HVLA them. But sometimes you can do that all and they're still going, aren't you going to crack my neck? Well, certainly I am. I'm sorry I forgot that. Why don't you tell me that 20 minutes earlier and I could have been done? Probably don't want to mention that one. Doing okay?
Mhm. I smell better now.
Good. All right, right before I go ahead and do the neck, the other thing you might want to think of is the sniff test. All right, so I want everyone to sniff. All right, now I want you to take your fingers, put them on your ears, and I want you to pull your ears laterally and slightly posterior. That's all of you. Now, I want you to pull just hard enough so you got the skin taut, okay? Now I want you to sniff. Better, right? Yeah. So, good thing to go. Good thing to teach moms. That kid keeps getting an ear infection, you know, teach them how to do that. Pretty soon the kid's going to know how to do that, and tell them, I'm serious on this part. I know it doesn't seem to be right, but it's serious on this part. Tell them that their ears won't stay permanent like this, because someone's going to tease them. It's like, oh yeah, my ears are going to be like this. It's like, well, they're probably going to be like that anyway. But no, your ears are not, because kids worry about that. So now I'm going after the OA and the mastoid processes, just trying to balance those. And I can just do a mild fascial release where I'm just got my fingers, I got pressure on it, I'm just following what we call the muscle movement on its own. We call it the creep. And again, if you're going to be late for clinic, go now. I don't make people stay. I don't ever want you to late to clinic, because that's another person angry at you. Make sure you sign in and what time you came. I do give half credit. I only crack your neck on one side, okay, as opposed to both. And then I'm going to work on C2 and C3. A lot of times I use some compression because the muscles are so tense, particularly going down the paraspinals of the cervicals and thoracics. And it gives me that little bit of opportunity to kind of do micro rotations. A lot of people will call this functional. Can't remember that. It'll come to me when I don't need it. There we go. My treatments all build up to the ultimate crescendo of HVLA. I do soft tissue, myofascial release, counter strain, all of it building up to that. Because I figure if that don't fix it, then I still got my last secret weapon. And it's not my charming personality either. I do a lot of talking, like that was a surprise. I try to get their mind off of whatever it is that's bothering them and distract them. When I ask them about movies they've seen, what they like to do for fun, you know, if they don't do anything for fun, that's their next assignment, do something for fun. Because remember, we're treating the mind, the body, and the spirit or the soul. Repairing any one of those or making any one of those makes a change in all three of them. It's like diagnosing in 3 planes and making a change in one of those planes. You've improved the whole system. Ideally, you want to make changes in all 3 planes, but you know, you take what you can get. Ready?
Okay.
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 Okay. Smile and relax. Okay.
Every time.
Every time. All right. Because I give them full treatments. That's why I'm doing the other side. All right. Wiggle your toes. All right. I feel better. All right. All right. You did wonderful. Here. And then you always help the patient up, because remember, you only guarantee to get them on the second bounce, okay? Because you don't dive and try to save their life, because obviously you throwing yourself under them is not going to be an outcome for you. I want to thank you for the opportunity to provide this structural exam. I especially want to thank the volunteers that came up. I hope to have more of these next time. Please remember your professionalism, and you were great in bringing that out. Oh my God, that was so great. We'll have to, use that as a snippet or something. Hey, you're touching me. I haven't gotten to you yet. I wanted to appreciate you for saving me as I'm lecturing and can't think up what that right word is, and for volunteering first, as well as having an excellent example of what COPD could be. And I do want to add the statement that I apologize for any of the sarcasm that I use. It is met in good fun. If you have taken offense to anything I've done, I deeply apologize, and I will be glad to talk to you and apologize much more deeply later. Until then, I want to thank everyone out there in Cyberland. Please remember to try and do at least 2 or 3 minutes of an exam. Remember that it's all connected, and someday you're going to teach someone else who really wants to learn it that doesn't have the same initials after our names like we do. Thank you. My pleasure.